Assalamu alaikum. Hello and welcome to the third General Neurology Virtual Forum. My name is Gerard Moore and I am the Technical Support Manager. I will just do a very brief housekeeping before I hand over to the Chairman for today, Dr. Ahmed Shatila. If you have any audio or video connection issues, you will see a red coloured reconnect button. That is located on your screen. If you press that, that will resynchronize your page and hopefully should sort it. If you continue to have issues, then maybe suggestion to change to a different Wi-Fi network or to your 4G for a more stable connection. If you have any private or admin matters, you will see there's an admin only button on the chat bar, and that will come directly to me as a private message. Please leave the chat bar for scientific comments and questions only, out of respect for those people that want to ask questions. So any non-scientific, please put to me in the admin only button. This is the first day of 3 days of the forum, and I will now hand over to the chairman, Dr. Ahmed Shatila, to do the official opening. Dr. Ahmed, the floor is yours.
Thank you, Gerard. First of all, I'd like to welcome everybody to the third annual General Neurology Forum. This is our third year doing this. This conference has grown considerably in size and in content over the past couple of years. And I think this is a result of the interest among our colleagues in learning about general neurology. While the conference has grown in size in both quality and as well as content, the core idea or the core reason why this conference was made in the first place was to provide a reliable source of information for our non-neurology colleagues to help diagnose, treat, and manage different neurologic illnesses. This is me. I'm Ahmed Shatila. I'm a consultant neurologist at Sheikh Shakhbout Medical City in Abu Dhabi. The conference today it's a 3-day conference, as Gerard had mentioned, and we'll start off first with a lecture provided by me on multiple sclerosis, and then there will be a lecture about diabetic neuropathy, headaches, epilepsy, and then finally lysosomal storage disease from a neurology perspective. I would like to thank our sponsors for sponsoring this event. Without their support, this event could not be possible. I would like to thank SSMC and Saha for hosting the event. Again, without their continued support, this conference would not be possible as well. And finally, Gerard from Focus Gold for organizing this event. But last but not least, I would like to thank the audience because, again, you guys are what makes this conference possible, your interest in learning about different neurologic diseases. So, as always, much appreciated. So, I'm going to be talking today about, I'll be starting off the first lecture, sponsored by Roche, When Early is Early Enough. Here are my disclosures. So when we think about multiple sclerosis is a relapsing remitting form of disease for 85% of the people who have the illness. And as you can see in this graph right here, usually patients with MS will start off with relapses, and most of the time they do recover from relapses. But over the course of the disease, and over a period of time, the relapses become less, the disability becomes to accumulate, as you can see here. And this is the main problem with people who suffer from MS, is that accumulation of disability over time. And the reason why is through the relapses that occur systemically over the course of years. Now, the main reason why people have disability from MS is because you have accumulation of white matter lesions. And the accumulation of the lesions are a result of neuronal destruction, demyelination that's occurring as a result of inflammation. So early on in the disease, even way before the disease has been diagnosed, in this area right here, there may be no symptoms, but yet you can already see there's already gadolinium-enhancing lesions, which is a sign of active disease. Then this is the pre-symptomatic area. And once you start getting diagnosed, or once you have clinical symptoms, you now notice that the inflammation increases. And with inflammation, usually we say that you need 10 lesions for any one clinical symptom. The gadolinium-enhancing lesions begin to accumulate, and over a period of time, usually between 10 to 15 years, what you notice is that the lesion or the active inflammatory lesions become to decrease, but then the disability becomes to slowly increase. And this is usually what we call the secondary phase of the disease, or SPMS. Water's good for you. In this famous study by Bruce Trapp, and what this now, MS was historically used to be thought, this was the first study that actually changed the paradigm of thinking in MS from a purely demyelinating disease to a neuronal destructive disease. So in this slide right here, what you see is you see an axon right here, and this is a myelinated axon. The green areas right here, these are areas of demyelination. And this red circular lesion right here, this is actually a transected axon. And what you're seeing is you're seeing ballooning of the axon because all of the information or all the axonal vesicles or transport vesicles are ending up right here at a dead end, and so it just balloons up. This was the first study that actually showed that MS is not just demyelinating, it's actually a destructive disease as well. And what you notice here on this chart right here on the right is that as time goes by, the amount of cells in a lesion will begin to decrease. And this is a result, again, of this active destruction of neurons. Okay. So, as I've mentioned, in the beginning of the disease, it is in the first portion of the disease, it is highly inflammatory. And what you notice over here is that you have an increased amount of inflammation in the beginning portion of the disease. And this is the area where we try to treat, because this is the area where we can make a difference. As time goes by, inflammation decreases, and then you get a steady increase of axonal destruction, neuronal destruction, and generalized brain atrophy. And this is where it gets harder to treat, because at this point, most of the treatments that we have for MS are for active inflammation. Oh, let me go back, sorry, double click. So, in this slide right here, this is just basically showing what I mentioned. Initially, we have the axonal, we got the active demyelination, or the active lesions. Now, what happens with time is that the lesion will, as I usually say, it's almost you get the smoldering lesion. Imagine like you have a bonfire, you have some coal. Initially, you have a big flame, but then eventually the flame dies down, and you just have the red fume from the charcoal. And this is what you're seeing right here. It's just a lesion that's just kind of burning slowly with inflammation. And with time, this causes black holes, causes axonal destruction, which leads to overall brain atrophy. So even though the disease starts early and the inflammation is really strong early, you can have symptoms even before you've been diagnosed. And why is this happening? Because again, like I said, you may have a lot of lesions before your first clinical attack even becomes apparent. In this study, in people who had CIS, clinically isolated syndrome, so in this group of patients, these are people who don't have yet MS. They have lesions consistent with MS. They may have one attack consistent with MS, but they don't meet the criteria, the diagnostic criteria to say they now have active MS. And what you notice here, even though these patients were not yet classified as MS, more than 60% of the patients already showed signs of failing greater than 2 cognitive domains, which were mainly memory, speed of information processing, attention, or executive function. When you compare to healthy controls, only 7%. So even though they're not diagnosed yet, even with the disease, they're already showing signs and symptoms of the disease. Now, why is there a big difference among patients? You know, it's not uncommon. You can see patients with MS. Some of them have a lot of lesions with minimal disability. Some of them have a few lesions with a lot of disability. And the reason why overall the lesion burden or the lesion volume is different is that there is a functional reserve capacity in the brain. And I always give the example, like, I'm going to use my cane right now. And I always tell my patient, what happens and I always give this example in clinic. If you have the cane and I say, if I hit you on the head with it, you're going to feel pain, right? And they usually nod their head and like, yeah, it hurts. Now, but you'll recover. You'll be fine. But let's say I hit you on the head 20 times every day for the next 20 years. What's going to happen to you? You're going to feel it. You're going to start noticing difference, problems. And that's exactly, in a nutshell, what's happening with your body, with your brains. When you're young and healthy, you get a lesion, you're able to recover from it. But with time, with that continued onslaught of inflammation and destruction, you're no longer able to recover from these lesions, and then you slowly start progressing. And that's a result of the fact that your functional reserve capacity has now decreased. Neurodegeneration becomes clinically apparent in an axonal length dependent manner, known as asynchronous progression MS hypothesis. So what does this mean? So if you look at this chart right here, it's classified into therapeutic windows. The first one is bladder, and it goes bladder, then the motor system to the legs, sensory symptoms to the legs, cerebellar, then you got the upper limbs. And what this means is that the longer axons are more likely to be affected than the shorter axons initially. You're more likely, if you have random lesions attacking your CNS, more CNS lesions, or the longer the nerve is, that's more likely to get injured first versus shorter axons, like the nerves go into your hands. But the problem is, as you go from window to window to window, the odds of getting improvement or actually making a change in treatment gets harder and harder. What does that mean? So if you have a patient, by the time the person gets down to having cognitive disability, you've already missed 4 or 5 windows before that. And even if you start treatment here, you're not going to notice the effect. You're not going to notice a drastic change in treatment. The goal of treatment is still by and far to prevent worsening. We do get improvement, but the main goal is to prevent worsening, because what's lost is lost. Time is brain. I'm going to take that from our stroke guys right now. If you lose it, it's very hard to get it back. Now, again, I told you, in MS, symptoms start early, and even before you're diagnosed, you may already show signs of disability or signs of cognitive slowing, even before you've even been diagnosed. So in this trial, or in this study, what they did is they classified 3 groups of people: patients with MS that were treated early. Gerard, could we minimize this camera a little bit, because it's kind of blocking a little bit?
Sure, yes.
Thank you. You have 3 arms here: people that were treated early and optimal treatment, people that were diagnosed but they decided not to be treated right away, and then the third group were the untreated group. And what you notice, if you were started treatment early, you had the lowest chance of having progression of disability. If you delayed your treatment, you did improve. You still had some reduction in disability, but not as much as the people who got treated early. And if you weren't untreated, those were the group of people that did the worst. So early treatment is beneficial. And the longer you delay your treatment, the more likely you are to not benefit or have a reduced benefit from your treatment. We already said earlier treatment in MS. This is another study which looked at the same thing. Earlier treatment and after MS diagnosis reduces your risk of disability progression versus later treatment. So in this study, they classified 3 different arms: from time to diagnosis to treatment initiation. If you did it within a year, or if you got treated 1 to 3 years after a diagnosis, or up to 3 years, there are 3 different arms, and each one of them were clinically significant. So just by delaying treatment by 1 year, you are not benefiting from the effect just as if you were being treated early. And if you waited more than 3 years, almost 70% of people or 30% of people, if they delayed treatment by 3 years, they already showed signs of disability. And that's actually something when we talk about MS, the first 2 years is really, studies have shown that the amount of lesion volume, amount of disability, amount of attacks that you get in the first 2 years of treatment can predict the next 20 years of your disease life. So that's why early treatment is important. Now, is there a difference between what you treat your patients with? Right now, currently, there's over 15 medications we have to treat MS. In this study right here, they classified 2 types of treatments: your high efficacy disease modifying treatments and your medium efficacy disease modifying treatments. So just by being in a high efficacy drug or on a low efficacy or medium efficacy drug, your probability of 6-month confirmed EDSS worsening. Now, EDSS is a scale that we use to classify people with MS based on their disabilities. 0 means you have no symptoms. 4 means you have at least difficulty walking 500 meters. 6, you're in a wheelchair. 10, you're dead. And you can notice just by using high efficacy drugs, there is a significant improvement on 6-month confirmed EDSS worsening versus people who use medium efficacy drugs. And on the other side of the chart right here, your probability of a first on-treatment relapse, whether you're on a high efficacy drug or a medium efficacy drug, they were significantly separate. That means you are more likely to be on the drug longer before you had the first relapse. And what's that important? Because I just said, your first 2 years of treatment can predict your next 20 years of disease life. So you want to treat early, you want to treat aggressively on patients because it can make a big difference later on. Now I'm going to talk to you today about ocrelizumab. Earlier treatment with high efficacy DMTs reduces the risk of disability progression versus escalation with ocrelizumab. So in this study right here, you had 2 arms. You had patients that were treated with interferon beta 1A, medium efficacy drug, and you had patients who were treated with ocrelizumab, 600 milligrams. It is a CD20 cell depleting agent. Now, in the first 2 years of the study, you notice the people that were treated with ocrelizumab significantly improved or were stable versus the people that were treated with interferons, significantly different. But the thing is, after 2 years, the patients that were on interferons got switched over to ocrelizumab, and they continued to follow. So if you're on ocrelizumab or Ocrevus, you continue on Ocrevus for up to 240 weeks. If you're on interferons, you were switched to ocrelizumab, and again, you were followed for 240 weeks. And what you notice is that, yes, both groups still had reduction of disability, but the people that were switched never caught up to their colleagues or friends that were started initially on the high efficacy drug. So basically what that means is earlier treatment, just by delaying the treatment by 2 years, they never caught up to other patients that were started earlier. In this slide right here, this is just basically consensus guidelines by the ECTRIMS, which is the European Committee for Treatment and Research in MS, and the EAN, European Academy of Neurology. Both of them recommend early treatment with disease-modifying drugs as early as CIS. Again, the MS Brain Health and the US National MS Society also recommend treating early with medications. What's the treatment goals with MS? You want to reduce disease activity. You want to improve symptoms of relapse, reduce the disease activity, and reduce the accumulation of disability. You also want to try to achieve something called NEDA, no evidence of disease activity, meaning no progression, no MRI lesions, no relapses, no brain atrophy, what we call NEDA 4. Now, in the OPERA-1 and OPERA-2 study, I briefly mentioned it before, but in the study, this was a double-blind, double-dummy study. What does that mean? Neither the physician knew what drug the patient was on, and the patient didn't know what medication they were on. So both groups got both medicines, but one of them was a placebo, one of them was the active drug. and it was for 2 years. And after 2 years, everybody on the interferon arm got switched over to the ocrelizumab arm, and ocrelizumab was given every 6 months thereafter. So what you notice right here, the patients on interferon, they had 0.27 relapses per year. That's the annualized relapse rate, so which is about 1 relapse every 4 years. The people on the ocrelizumab arm had 0.14 relapses, so that's 1 relapse every 7 years. And what you notice, at the first 2 years, you did have the ocrelizumab arm and the interferon arm. And after year 3, everybody was switched to the ocrelizumab arm, and they were followed for 6 years. What you notice, there was definitely significant improvement versus the interferon arm, but this improvement was sustained for 6 years. And by the time you got to year 6, instead of having a relapse every 7 years, now you're having a relapse 1 in every 20 years. The relapse rate, or annualized relapse rate, is 0.045. So not only was it drastically reduced, it was consistent and maintained for the next 6 years, which is a good thing. When you look at whole brain volume, again, as I say, brain volume or brain atrophy is the most important predictor of long-term disability, and there was a difference whether you're treated on interferons or on ocrelizumab in this trial. What about clinically confirmed disability progression? Again, as I told you, there was a 57% reduction in confirmed disability progression up to 264 weeks after study, whether you're on the interferon arm or if you're on the ocrelizumab arm, you had a 57% risk reduction of confirmed disability progression. But what about improvement? Now here's something, with the new medications that we now have, the aim is no longer just about stability. We do sometimes see improvement. And in this study, not only did people have stability, a reduction in relapses, reduction in active disease, reduction in brain volume atrophy, some patients actually improved. And actually, I always give the story, my first patient, one of the first patients in the UAE was starting ocrelizumab at our hospital. And when I saw the guy, he was in a wheelchair. And after he got his ocrelizumab, he's now using a cane. So it's not often, but when it happens, it can change someone's life. So in summary, in relapsing remitting patients treated with ocrelizumab versus interferon beta 1A, they had a reduced relapse rate and a reduced level of disability, which is maintained over time. Furthermore, after following a switch from interferon beta 1A, patients experienced a subsequent rapid and robust reduction in relapse, as I had showed you. In PPMS patients, this drug is approved for primary progressive patients. I didn't talk about this today, but it is FDA approved and EMA approved for primary progressive patients. That's another lecture for another time. Both the OPERA-1 and OPERA-2 trial, which was the study, the phase 3 trials which got approved for this drug, showed a significant improvement, not just in relapse rates, brain atrophy, confirmed disability improvement, confirmed disability progression over the first 2 years, but that was sustained and managed for up to 6 years later. So with that, I will end my presentation. Thank you very much. If there's any questions, please feel free to ask.
Thank you, Dr. Shatila. There were no questions so far.
Okay, so we will then,
Yes.